This amendment has to do with the professional work of registered nurses and their ability and authority to make sure that the patients in their care are getting adequate and safe care in our hospitals. We have had an unfulfilling debate over the last number of years here in the legislature about how we properly staff our hospitals. The nurses continue to express their concern that there is inadequate staffing, that they often are facing inadequate staffing, and while we have had hearings about that, they've always been informational, and we've not really done the work of responding to their continued concern. Our hospitals will also say that it is a chief concern of theirs to make sure that the patients inside the walls of their hospital are getting adequate and excellent care. And in this case, the nurses in the hospitals seem sometimes to be opposing one another in the solution when we talk about staffing ratios. Back in 2001, there was a labor dispute here in Minnesota, and the result of that was giving the nurses in certain hospitals the authority to temporarily close a unit when they believe there are too many patients in their care to do the work safely. This is now done in at least 11 hospitals in the state of Minnesota. It's rarely used, but it's a stopgap. It is a way for the nurses to say, pause. It is a way for the nurses to articulate their professional authority that in their judgment, there are too many patients being cared for, and the result is a lack of safety. It puts the decision in the hands of the professionals doing the work. I want to tell you just a very brief story about my early practice, an example where this policy would have been helpful. My first job was in Marshfield, Wisconsin. It is a big hospital in a very rural community, and I worked overnights like lots of nurses do. I took care of patients on a 50-bed unit, patients with medical conditions like diabetes and heart failure and kidney failure and liver failure. And I was assigned one night with one other registered nurse on that 50-bed unit and a couple of nursing assistants. So we started the night understaffed. On that night, I had a patient have a cardiac arrest. It was the first time that happened to me. That was a memorable experience because I was in the room with the gentleman when he arrested, and I was the one who was first there to resuscitate him. When you call a code in a hospital, a team comes to care for that patient, but you have to stay with that patient as well. They're your obligation, they're your assignment, they're your responsibility. On that night, I also had a person who had recently been discharged from the intensive care unit. He was newly extubated. He had a breathing tube in his throat, and he'd had that for some time. They had just removed that breathing tube. They had discharged him from the intensive care unit where you have usually 1 or 2 patients. So when you're in the intensive care, you're getting a lot of attention from your nurse because there's only just a couple of people that you're caring for. He was transferred from there to a unit where he had me and one other registered nurse, and we had lots and lots of patients. He was afraid. He was afraid because it was the first time that he was on his own overnight, and he was afraid he couldn't breathe. And I had a patient that night who had a GI bleed, which means that she was bleeding from her bottom. And we needed to get her into surgery, and we needed to get the surgeons to come to do that work. I had those 3 patients along with other patients in one night. I worked in a rural community. We couldn't get extra staffing to come in that night. It took hours for us to get extra staffing to come in. We were beyond our limits at that point, and if we had had to accept an admission that night, it wouldn't have been safe. I would have liked the authority to say no. I didn't have that authority. We worked our tails off that night. I was a pretty new nurse. It was pretty scary. And if we listen to nurses, and those of us who are serving on the Health and Human Services committees have heard these stories, we all know that we have hard days at work. We do too here. But when the nurses are saying there are too many examples in which the staffing is such that we are not safely caring for Minnesotans, we need to listen to that. We haven't been able to come together around the idea of a ratio. We haven't been able to come to a consensus about that here in the legislature or outside in Minnesota. This is another way to tackle that problem, and it's already proven, it's already working in a number of our hospitals, It doesn't mean we close the emergency department. It doesn't mean we close labor and delivery. But it does give the professional registered nurses the authority to say, hold on, pause, let's rethink this. Let's strategize to make sure that the patients coming to this unit are getting excellent care. If we agree that we want Minnesotans to get great care in our hospitals, as the nurses are saying they do, and as the hospitals are saying they do, then this is a remedy that brings us to that point, unit by unit.